Hello everyone, my name is Dr. Stewart. Today I will be lecturing on urology. This will be a twofold lecture which will include common GU complaints for adult male and female patients, and also a second lecture which will cover a brief overview of common pediatric GU complaints. With that being said, we've got a lot of information to cover, so let's get started. And as always, please feel free to contact myself or one of the instructors if you have any questions or concerns about today's lecture. A urinalysis can be performed on both clean catch or sterile straight cath urine specimens. A urinalysis provides information about hydration, protein, glucose metabolism, blood, and bilirubin. A urinalysis can be performed with a chemical examination with a dipstick and or with a microscopic examination with a microscope. The chemical examination with the dipstick will reveal information about the urine pH, the specific gravity, glucose, ketones, nitrates, white blood cells, and leukocyte esterase, urobilinogen, protein, and blood. For the purposes of this urology lecture, I want to point out 4 key indicators on the dipstick. pH is an important indicator for urology to help rule out infection and kidney stones. Nitrates are also an important indicator in urology and are sensitive but not specific for a urinary tract infection. Normally there's no nitrates present in the urine. However, certain bacteria can convert to urinary nitrates. But negative nitrates do not rule out a urinary tract infection. This means that you can have a patient who comes into the office who has a urinalysis completed and they have no nitrates present, but their urine culture comes back positive for urinary tract infection. You can also have a patient who comes into the office for urinary tract infection symptoms who have positive nitrates and their culture will return positive for a urinary tract infection. Leukocyte esterase is present when white blood cells are being lysed. As white blood cell levels increase, the leukocyte esterase value increases. This means that leukocyte esterase indicates pyuria, which may be suggestive of a urinary tract infection. Blood in the urine can also be an indicator of infection, stones, or a GU malignancy. Now, the microscope examination is important to consider if your office does have a microscope to inspect a urine sample under high power field. It is beneficial in showing the number of white blood cells, red blood cells in a magnifying view to determine whether further workup with imaging or testing may be necessary. For example, you may have a patient who comes into the office for a routine physical exam. You do a urinalysis on them and you find that they have greater than 3 red blood cells per high power field on the microurinalysis. You look back in their previous records and you see that this is their second or third occasion that they've had 3 red blood cells per high power field noted on the micro UA. You decide to do a CAT scan, and you might also consider doing a urologist referral for a diagnosis of microhematuria. Another example may be if you have a patient come into the office with urinary tract infection symptoms. You realize that the patient gave a urine sample, but it's stained because they've been taking pyridium or azo over the counter to help with their irritative symptoms. You realize that you can't do a dipstick and that a micro UA is the best course of action to see if there's any white blood cells or red blood cells or any epithelial cells under the microscope. Micro UAs are also helpful in locating epithelial or skin cells to help rule out a contaminated urine sample. The image on the left-hand side is what the back side of a urinalysis container looks like. In order to perform a urinalysis, a test strip is dipped into a collected urine sample and is then held alongside the back of the container to interpret the results, which are color-coded. Urine samples can be sent for culture to confirm whether a urinary tract infection is present. When an infection is present, the results return with the type of organism, how much the organism is present, a list of antibiotics or a sensitivity report outlining the medications which the bacteria is sensitive to or resistant to. The minimum inhibitory concentration, or the MIC, is the lowest concentration of drug that inhibits the growth of an organism. The MIC is used to further evaluate the pharmacokinetics and pharmacodynamics of a certain drug. MICs are not directly comparable to one another, so choosing a drug with the lowest MIC is not necessarily helpful. In the above picture, you can see that the status of this particular urine culture is final and not preliminary. That's important to recognize. The organism that was found in this urine culture was E. coli, and there were 100,000 colonies or organisms present per ml from the given urine sample. The antibiotics are listed on the left-hand side. The susceptibility results are in the center. The S stands for susceptible, meaning that it will treat the infection. R stands for resistance, meaning that it will not treat the infection. The MIC is alongside the right side of the susceptibilities. And it's important to know that and understand that which drugs are going to be effective for your patients. You need to understand which drugs will best penetrate the body system or the organ which is infected, and also be familiar with resistance reports in your surrounding area of practice. Dysuria is a common urological complaint, and it occurs when chemical irritation or inflammation alter the mucosal barrier and stimulate the nerves just beneath the urothelium of the bladder. Chronic stimulation of these nerves, seen in chronic dysuria, can alter nerve sensitivity and lead to persistent pain. Patients presenting with dysuria may have subjective complaints of pain or burning, stinging, or tingling of the urethra with urination, which can be felt externally or internally. Common causes of dysuria include infection, such as an STI, vaginitis, or prostatitis, bladder or lower urinary tract problems, such as cystitis or pyelonephritis, nephrolithiasis, which are kidney stones, neoplastic conditions such as bladder tumors, or trauma or idiopathic. Associated symptoms of dysuria may include vaginal symptoms. Is there discharge, irritation, or atrophy present? Or lower urinary tract symptoms, or LUTs? Is the patient experiencing frequency, urgency, and nocturia? It is important to obtain a thorough history and also to complete a physical exam of the vagina if atrophic vaginitis is suspected, a DRE or digital rectal exam if prostatitis is suspected, and evaluate for CVA tenderness if pyelo is suspected. Diagnostic testing for dysuria includes a urinalysis and possibly a urine culture, renal function test, a culture of the urine and possibly also blood cultures, STI testing, and possible imaging. Another common urological complaint is hematuria. Hematuria can be gross or microscopic. Transient hematuria means that it occurs on one occasion. Persistent hematuria means that the hematuria occurs on 2 or more consecutive occasions. Urine color can range from light pink to tea-colored to cherry red to dark red. Diagnostic criteria for hematuria is when greater than 3 red blood cells are present per high power field on a microscope. Some contributing factors to hematuria are medications such as anticoagulants or aspirin, if a patient's on Herminses, a urinary tract infection, kidney stones, ruptured hemorrhagic renal cysts, prostate disorders such as benign prostatic hypertrophy or BPH, and prostate cancer, if there's a trauma, if there's a neoplasm within the urinary tract, in the kidney, the urethra, the bladder, or idiopathic. Patients presenting with gross hematuria or patients who are found to have microhematuria should be evaluated for CVA tenderness, abdominal pain, suprapubic tenderness, urethral discharge, and a tender or enlarged prostate. A urine with micro should be performed to confirm whether 3 or more red blood cells are present per high power field on the microscope. A culture and sensitivity may be considered if the patient is exhibiting signs and symptoms of a urinary tract infection. A CBC may be considered to rule out anemia if the patient has been experiencing gross hematuria for some time. If the patient is on an anticoagulant, coags should be ordered to ensure levels are therapeutic. Imaging with either a CT stone study or a CT urogram and a referral to a urologist for a cystoscopy should be made for patients who are experiencing gross hematuria and or who have a confirmed microhematuria to rule out kidney stones and neoplasms. Overactive bladder, or OAB, is another common urological complaint. OAB is a syndrome of urgency, frequency, and nocturia associated with involuntary contractions of the detrusor muscle with or without incontinence. The causes of OAB are multifactorial, such as urinary tract infections, ingestion of alcohol and excessive caffeine, certain medications such as diuretics, neurological conditions, and anxiety. Because many factors can contribute to OAB, it is a diagnosis of exclusion. However, urodynamics testing may be helpful to determine the function of the bladder and to confirm whether or not detrusor overactivity is present. It is important to discuss behavior modification with patients, including caffeine and alcohol reduction or elimination, and curtailing fluids throughout the day and prior to bedtime. Antimuscarinic agents and antispasmodic agents are commonly prescribed medications to treat OAB. Antimuscarinic agents help block the parasympathetic stimulation of the detrusor muscle by blocking acetylcholine. Antispasmodic agents help to relax the smooth muscle of the urinary bladder. More invasive treatments for OAB from a urologist might include bladder Botox, interstim, and PTNS. Normal bladder function stores and expels urine. Continence depends on proper function of the detrusor muscle, which contracts, and proper function of the urethral sphincter, which maintains a closure pressure under the control of the nervous system. In storage mode, the urethral closure pressure exceeds the abdominal pressure. In normal voiding, the urethral pressure falls and the bladder pressure rises, allowing the detrusor sphincter to open. Urinary incontinence is the involuntary loss of urine from the bladder. It is very common, but usually abnormal, and it's vastly underreported. There are several types of urinary incontinence: stress, urge, mixed, overflow, functional, and reflex. Stress incontinence occurs when there is an involuntary leakage of urine due to exertion, which raises the intra-abdominal pressure. It can occur during coughing, laughing, sneezing, lifting, or standing. Risk factors include the female gender, childbirth, and obesity. Management for stress urinary incontinence includes Kegel exercises, biofeedback, pelvic floor therapy, weight loss, and surgery. Urgency incontinence occurs when there is an involuntary leakage of urine preceded by a very strong desire to void immediately and inability to delay voiding. It is a part of the overactive bladder syndrome. These are the patients who will come into the office and they'll tell you they're going 6, 7, 8 times during the night. They're going every half an hour, 45 minutes during the day, and they are familiar with where every single restroom is in every place that they go. Management for urgency incontinence includes behavior modification, such as curtailing fluids, caffeine reduction, reducing citrusy foods and drinks, acidic foods and drinks, time voiding, And the reason why you want to tell patients to avoid citrusy and acidic foods and drinks is because those things are acidic and they are very irritating to the bladder. You might want to talk about introducing antispasmodics or antimuscarinics, as we discussed in the previous slide. It is important to note that antispasmodics and antimuscarinics have a high risk of adverse effects such as constipation, dry mouth, dry eyes, and urinary retention. So you want to use this with caution and at a very low dose as possible in the elderly. There's the Botox injections, as we discussed, for treatment of OAB, the InterStim, and the PTNS, the same as OAB as well. Mixed incontinence is a mixture of stress urinary incontinence and urgency incontinence. The treatment of mixed incontinence is a combination of methods between stress incontinence and urgency incontinence. Overflow incontinence occurs when there's an involuntary leakage of small amounts of urine caused by urinary retention and overdistension. So what this means is that the bladder has met its capacity, and because of that, urine just continues to flow because the bladder cannot hold anything else. This results in continuous and infrequent loss of urine throughout the day. The patient's complaining of urgency, frequency, voiding small volumes throughout the day. There might be some hesitancy, poor flow rate, and nocturia. Risk factors for overflow incontinence include pelvic or abdominal surgery, an enlarged prostate, constipation, pregnancy, and neurogenic bladders. Management for overflow includes treating the underlying condition. For example, if a patient has an enlarged prostate and they're not able to expel all the urine out of their bladder because their prostate is enlarged, you might want to consider adding an alpha blocker such as tamsulosin or Flomax, or considering having the patient consider prostate surgery if they've maxed out on their medications to alleviate the obstruction. Patients might come in and say they have to do a Creed maneuver, or they're pressing on the lower part of their abdomen in order to feel empty. And then also you might want to recommend time voids. Functional incontinence occurs without underlying cause. It's associated with cognitive or physical defects such as delirium, or medications such as diuretics, narcotics, decongestants, or alcohol. The treatment, again, is dependent upon the underlying condition. Reflex incontinence occurs due to neurological damage or a neurologic or congenital anomaly, which results in failure of the bladder to store or empty urine, or both. Symptoms include urgency, urge incontinence, frequency. They're not emptying their bladder very well. They're getting recurrent urinary tract infections, and they have a loss of bladder content. So that means they're just incontinent. Management includes treatment of underlying condition. In these patients, you might want to consider a long-term alternative, which is an indwelling Foley, urethral catheter, or a suprapubic catheter. Other things to think about with urinary incontinence is to obtain a thorough medical and surgical history, and also to get a thorough voiding history as well. Your physical exam for the patient presenting with complaints of incontinence may include a discussion of their current medical condition. Does the patient have a history of a stroke, Parkinson's, diabetes, MS? These patients will be at higher risk for developing overflow incontinence and also reflex incontinence because of their underlying neurological disorder, which predisposes them to developing a neurogenic bladder. It is important to consider the possibility of long-term bladder catheterization in these patients. It's also important to consider what is the functional and cognitive ability of your patient. Are they delirious, or do they have dementia? On an abdominal exam, are they constipated? The same nerves which go to the bowels also control the bladder. So if patients aren't having regular bowel movements and they're constipated, then they're probably also having issues with urination, which can lead to urinary retention and then lead to overflow incontinence. On pelvic exam, is there a uterine prolapse? Is there a rectocele or cystocele present? If so, then a referral to an OBGYN or urologist is warranted. Testing for incontinence might include a urinalysis and culture and sensitivity to rule out infection, a chem panel to make sure there are no abnormalities with electrolytes or abnormal elevations in blood sugar, post-void residual to make sure there's no significant urinary retention present, urodynamics testing to test the function of the bladder, determine if there's any detrusor overactivity, and to confirm urge or stress urinary incontinence, a cystoscopy to make sure there's no abnormalities of the bladder, the urethra, or the prostate, and imaging with either a renal ultrasound or CAT scan to make sure there's no significant hydronephrosis or kidney stones in the urinary tract. Acute urinary retention commonly occurs in patients with a pre-existing partial bladder outlet obstruction and who experience a decrease in detrusor pressures or a sudden increase in outlet resistance. Precipitating factors for acute urinary retention include medications such as anticholinergics, antihistamines, analgesics, and antipsychotics, acute infection such as the urinary tract infection, gross hematuria. These patients are coming in clot retention, so they have so much blood in their bladder that they're not able to pee because it forms into a clot. Constipation, remember as we discussed, if you're not pooping, then you're not peeing as well. Urethral strictures, so narrowing due to scar tissue along the urethra, preventing urine from coming down the urethra from the bladder. A bladder neck contracture, that can result after a TURP procedure, which is a procedure for alleviating an obstructed prostate. So the bottom portion of the bladder can become narrowed, preventing urine from exiting the bladder down the urethra. An enlarged prostate, or BPH, advanced prostate cancer, and a neurogenic bladder. So the patients who have underlying neurological disorders, their bladders don't work anymore. So what's the workup entail for a patient who comes in with acute urinary retention? You want to make sure that you're directing your workup to quickly determine the underlying etiology of the acute urinary retention. So you want to obtain a thorough history. Has the patient ever had a history of a urethral stricture? Has the patient ever had any surgery to the prostate? Have they had any urological surgeries at all, including prostate removal? How are their bowel habits? Are they having regular bowel movements? Are they taking any medications that could cause urinary retention, such as chronic opioids or antipsychotics? Is the patient having urinary tract infection symptoms? A physical exam should include a digital rectal exam to assess the prostate, also palpation of the suprapubic area to confirm whether or not a distended bladder is palpable. Management includes initial management includes prompt urinary drainage with a catheterization. So prior to that, I would recommend doing a post-void residual to make sure that the patient is in fact retaining urine. And if they are retaining urine, up to date is recommending that anything over 300 cc's should be catheterized. You might consider doing a UA and a culture and sensitivity if infection is an issue, a chemistry panel, because if this patient has been in urinary retention for a while, then their renal function test might be off. You might want to consider a urology consult if you're unable to place a catheter because of a urethral stricture or a bladder neck contracture. In those cases, then a urologist is going to have to dilate the stricture or dilate the bladder neck contracture, either at the bedside, in the emergency room, or in the OR if they're not able to do it at the bedside. Coude tip catheters are recommended for men with BPH.